it's interesting actually if you look at the targeted therapies and in CLL. So with the B-cell receptor inhibitors, you don't eradicate disease, but patients will stay on the therapy for prolonged periods of time with detectable, even sometimes palpable disease, and not be progressing. And so they, and I've had patients who've been on treatment for over 4 years and are still, on treatment with detectable disease, and they don't seem to be progressing through it. Whereas with Venetoclax, what you tend to see is the ones who have a profound response and go MRD negative and have a complete response have a durable remission, but the ones who have a partial remission, after a period of time, they tend to start progressing. So it's different in the way they behave with these targeted treatments, I think. I think we are seeing patients now who have been through numerous lines of therapy and are becoming resistant to all the treatments. I think the CAR T cells is a challenge in that setting. I mean, it's a very attractive thought, but a lot of our patients are elderly. They've often had the toxicity of previous therapies. They've not got a good immune system generally, so it's where you place it in CLL. I think it's more likely we're going to be looking at combinations. So Venetoclax combines well and seems to be synergistic with antibodies, potentially with chemotherapy, potentially with other targeted treatments such as ibrutinib. So I suspect what we're going to see is those combinations coming along. Different novel antibodies, bispecific antibodies, for example, emerging. Doesn't look like the checkpoint inhibitors have a particular role in CLL, non-transformed CLL. And I suspect the evidence would suggest that the earlier we use the therapies, and that's what we're moving towards, the less we're going to see those really multiple resistant patients. So I think it's probably something we're going to deal with more now because we've got this group of patients that have had all these therapies. But then moving forward, we're going to see ibrutinib being moved into front line for 17P and in second line for chemo, and therefore they're not going to be as heavily beaten up, if you like.